Hello everyone, so today we'll be looking at epilepsy according to NICE guidelines. This is not the full guidelines, so if you want the full guidelines, here's a link to it. My other references include Oxford Handbook of Clinical Medicine, the 10th edition, patient.info, and also gov.uk for epilepsy and driving. So before we get started, let's get familiarized with the terms used in this presentation. So epilepsy, what does it mean? At least two unprovoked seizures more than 24 hours apart, or one unprovoked seizure and a chance of another seizure of at least 60% in the next 10 years. You might think, how do we know the probability of another seizure in the next 10 years? Usually, I think, if I'm not mistaken, it can be calculated using an EEG. So after usually EEG will only be done after 2 seizures, but in some cases, the specialist might decide this person needs an EEG after their first seizure. So after the first seizure, they do EEG, and then in the EEG, you see something known as unequivocal epileptic form activity, and then this has a high chance of another seizure. So that's where this comes from, I guess. And then also epilepsy is a diagnosis of an epilepsy syndrome. So syndrome, is a set of symptoms. We'll see what epilepsy syndrome means in the next page. So next term is epileptic seizure. So seizure, it can be epileptic or non-epileptic. Epileptic means that it's because of excessive or synchronous electrical activity in the brain. And then the specialist, basically it's either a pediatrician or a medical practitioner who who has a training or some experience in epilepsy. So significant amount of their workload related to epilepsy. And then one level up from the specialist is the tertiary epilepsy specialist. It's an adult neurologist who devotes a majority of their working time to epilepsy and works in a multidisciplinary tertiary referral center with lots of facilities and subject to peer review. And then epilepsy syndrome, we mentioned just now. So what does it mean? It's a distinctive disorder identifiable on the basis of typical age of onset, seizure type, specific EEG characteristic, and often other features. So a set of different things, you call it epilepsy syndrome. And then seizure type, we actually learned this before. It's the absent seizure, focal seizure, generalized tonic-clonic seizure, myoclonic seizure, or tonic or atonic seizure. So these are seizure type. Okay, so a quick recap on how we classify seizures. You have focal seizures and generalized seizures. Focal seizures, you can have impairment of consciousness or without impairment of consciousness. Whereas generalized seizures, you have absent seizures, tonic-clonic seizures, myoclonic seizures, atonic seizures, and infantile spasms. And then also, focal seizures can evolve into generalized seizures. You call it focal seizures evolving to bilateral convulsive seizure, or the older name is more simple, so secondary generalized seizure. And these are some of the symptoms that you can experience based on the lobe of the brain that is affected. So temporal lobe, is a memory, right? So you can have things like deja vu, jamais vu, everything strangely familiar, unfamiliar. Or you can have emotional disturbance. We know memory is strongly tied with emotion. And also the olfactory area is around here. So you have hallucinations of these modalities. Frontal lobe, we know the precentral gyrus is in the frontal lobe. So motor disturbances, you can have posturing, pedaling of the legs, motor arrest, Jacksonian march, thoughts, palsy, dysphasia. And parietal lobe, you have sensory disturbance, tingling, numbness. Occipital lobe for visuals or visual disturbances, you can see spots, lines, or flashes. And quick recap on how we take a history in loss of consciousness. So epilepsy basically use the normal loss of consciousness history taking. So what happened? You have to think what happened before, what happened during, and what happened after. So in epilepsy, before you want to ask, what were you doing when you had a fit? You have bright There are bright lights that trigger. Maybe you're at the disco, you saw some bright lights, and suddenly you have a fit. So probably it's the trigger. Then some people might feel an aura before they have their seizure. These auras can be any of these symptoms. You can have maybe this person sees spots or lines or flashes before they have the seizures, and then during you ask about motor symptoms. So are they stiff or flaccid, and then were they jerking? Stiff or flaccid, maybe you have atonic seizure, then the rest you have stiff, and then um, flaccid also you might think of syncope as well. And then how long was the seizure? Usually you have to ask this collateral history for this one because the person is unconscious. So ask a observer, anybody with them. And then after they realize any tongue biting or incontinence after that, and sometimes you can have post-ictal, especially for generalized seizures, you can have post-ictal confusion and drowsiness. So how long does it take to recover back to normal? So here's a case of Ali, 17 years old. He you took a history. He came in and he said he has a seizure. So you take a history from him. What happened before? So he was at the disco when he was having a seizure. He was drinking a lot. Were there any drugs? You asked, but he denied. But you can't be sure, so you have to check his urine and all. No aura. He didn't complain any aura. It just come on suddenly. Actually, alcohol suppresses brain activity. So don't quote me on this, but alcohol should not cause seizure. Withdrawal of alcohol will cause seizure, might cause seizure. Okay, during. So he went with his girlfriend, and the girlfriend witnessed the whole thing. Her whole, his whole body was stiff, and then his eyes rolled up, and he was jerking, sawan. Lasted for 3 minutes, and then after that, he realized that he wet himself, and he was drowsy for about 20 minutes before going back to normal. So some of the relevant after taking history, you take physical examination. Some of the relevant physical examinations that you should take according to NICE are cardiovascular examination, thinking of syncope, neurological examination, mental state examination, and developmental assessment. What's your role at the GP? So you have to think of the differentials. Is this a syncope? Think of other things. These are some of the differentials you can think of. And you have to ask the question, is this an epileptic seizure? So we saw what an epileptic seizure is in the beginning of this video. It's a seizure caused by excessive or excessively synchronous activity, electrical activity in the brain. If yes, it's not up to you to decide whether it's epilepsy or not. NICE actually emphasizes this quite a lot. It's not up to you have to refer to the specialist. It's not up to the general practitioner to diagnose epilepsy. So you only think whether it is an epileptic seizure or not. If you think it's an epileptic seizure, you need to urgently, within 2 weeks, refer to the specialist in epilepsy. And also, you have to educate the patient importance of reporting further attacks, and also teach them first aid. We'll touch on first aid later on. So what if another seizure happens? What are you supposed to do? Investigations as a GP, some of the investigations that you can order are ECG, probably thinking of some sort of heart rhythm disorder that might cause a syncope, or you look at bloods, look at electrolytes, glucose, calcium, which might cause the seizure. EEG and neuroimaging usually ordered by a specialist, but as a GP also you can order, probably the facility is not there, but in an ED, in the emergency department, they might order a CT if a stroke, if a TIA or stroke is if in acute situations, if they suspect TIA or stroke. EEG usually ordered by specialists. Neuroimaging also usually ordered by a specialist. MRI is preferred. Obviously, because MRI has more soft tissue details compared to CT, but CT is much faster, much cheaper. So CT might be done if MRI is not available, or MRI is contraindicated. Maybe you have a metal implant, or sedation is required for children. So Usually children will move around a lot, and then you can't make them sit still, right? And then you have to sedate them, and then you expose them to further risk of sedations. So you might want to consider a CT instead of MRI in these cases. A nice quality statement. So NICE emphasizes that the specialist is the one who diagnoses and manages epilepsy. And the rationale behind this is because in the GP setting, lots of misdiagnosis occurs. And as much as 5 to 30% of epilepsy is misdiagnosed. And I think I got the slides order wrong. So this is the reason why you want to refer to a specialist. Oh, yeah, correct. So this is the reason why GP cannot handle epilepsy. Why so many misdiagnoses? So in the management of epilepsy, you want to give anti-epileptic drugs, and the principle is that other than you have to um, discuss with the patient and the patient family about side effects, which one is a joint is a how do you say shared decision making. Other than the principle of shared decision making, another principle is you want to treat the epilepsy uh, on the basis of the epilepsy syndrome. And if it's not clear at presentation, you want to treat it based on the seizure type. So not all epilepsy you give the same drug. Some drugs might exacerbate certain epilepsies. So we'll see why specialist is required, because look at this epilepsy syndrome. There's so many syndromes, so with all these weird names. Maybe some of them you heard before, but most of them are there are so many of epilepsy syndrome, and there are so many anti-epileptic drugs to choose from. So it's very easy for somebody who's not specialized in epilepsy to make a mistake in diagnosing any of these syndromes. So role as a GP is to refer to specialists if you think it is an epileptic seizure, according to NICE lah. And then this is seizure type. So absent seizure, you give ethosuximide, and then the rest. I'm not gonna go into each of this. You can look at it yourself in your own time. But what we do need to know is that sodium valproate is teratogenic. So all women with on AED, not just sodium valproate, should be offered 5 mg per day of folic acid before any possibility of pregnancy. And is quite emphasized in NICE guidelines as well. Do not offer sodium valproate to women or girls of childbearing potential, unless other options are ineffective and pregnancy prevention program is in place. Pregnancy prevention program basically is contraception. Contraception is quite complicated in epilepsy as well, because a lot of the anti-epileptic drugs are CYP450 enzyme inducers, and then any progesterone containing um, contraceptive pills and all that will be affected by this. And then another thing is estrogen. Both estrogen and progesterone are a problem. So progesterone ones won't work very well, and estrogen ones you will actually decrease the levels of lamotrigine, if I'm not mistaken. Let me see. Where's my speaker notes? Lamotrigine, yes. So lamotrigine's levels are affected by estrogen. Estrogen decreases lamotrigine levels, so it's quite complicated. So, and when do we need to refer to a tertiary specialist? We talk about the tertiary specialist is one step above the specialist when there's diagnostic doubt, or when there's treatment failure, or when it's complicated. And I don't know what's with the obsession with the number 2. So epilepsy is not controlled within 2 years, or management unsuccessful after 2 drugs, or child under age of 2 is considered complicated. or you have other problems here. And how do we stop the AEDs? The principle is you have to be seizure-free for at least 2 years, and then you have to discuss with the patient about the risk of if you stop this drug, you might get a seizure. And then if they are on more than one drug, stop one drug at a time and stop each drug slowly over at least 2 to 3 months. For benzodiazepines and barbiturates, you need longer, 6 months. So you see Ali again. It's your off day. You see Ali at the local shopping mall. He saw you too, and he waved at you when he suddenly dropped to the ground and started fainting. What do you do? So first aid for uh, seizures. So check for danger. Any dangerous objects around him. Maybe a trolley is there. You move the trolley away from him. Maybe sharp objects, you move it away. Any like big necklaces that might choke him, take it out. Glasses, take it out. Do not restrain. If you have a pillow, put it under his head, but probably in the shopping mall, no, you don't have a pillow. Do not restrain him. Wait and time. So you look at the time. If it stopped within 5 minutes, you put him, check away, put in recovery position. If still feeding more than 5 minutes, this is convulsive status epilepticus. And how do you manage convulsive status epilepticus in the community setting? Any of buccal midazolam 10 mg or rectal diazepam 10 to 20 mg or IV lorazepam, but usually in the community you wouldn't have IV access and resus facilities. So usually buccal midazolam, buccal in the mouth midazolam, rectal diazepam, one of these. And then after you give, you wait another 5 minutes. And then if they still fitting after 5 minutes of giving this, call an ambulance. Some people, it might be the first time that they're having the convulsive status epilepticus and they don't have buccal and rectal diazepam with them. So what do you do? So after the 5 minutes, you know this convulsive status epilepticus, just straight away call the ambulance because you don't have this, this is their first time presenting with a prolonged seizure, more than 5 minutes. So they don't have these drugs with them. Right. And then ambulance bring them to hospital. What the doctors do in the hospital? ABCD, and airway, secure the airway, breathing, assess respiratory function, check the lungs, give a high concentration oxygen circulation, assess the cardiac function, and get IV access, large bore cannula in the large veins, and then check their blood glucose. And in the hospital, they will give IV lorazepam because they have IV access. But if IV access not available, yeah, if lorazepam is not available, you give diazepam. If no IV access, buccal midazolam. So this maximum you can have 2 doses, including the pre-hospital treatment. So pre-hospital treatment is the one here. So if you haven't given anything because he doesn't have the drug, then you can give this 2 doses of this. You can try 2 times. But if you already give 1 time in the community, then you can only give 1 more time in the hospital. So max 2 doses, including pre-hospital treatment. Then second line, see if seizures continue, IV phenobarbital or IV phenytoin. There's actually a very detailed table on NICE guidelines about this. If you're interested, you can go and look at it. And then if they have a very, very long seizure up to 30 to 90 minutes, it's known as a refractory status epilepticus. And this is usually managed in ICU under general anesthesia. And lastly, epilepsy and driving. If you have a seizure that causes a loss of consciousness while awake, you need to inform DVLA and your license will be taken away. So there are 2 types of licenses. You have the personal one and you have heavy vehicle one. Like always, the personal one is more lenient than the heavy vehicle one. Personal one, if it's a one-off seizure, you can reapply after 6 months being seizure-free. If it's a seizure due to changing of the dose of medication or changing of medication, you can reapply after 6 months being seizure-free. If more than 1 seizure, you can reapply after 1 year being seizure-free. Whereas for a heavy vehicle, it's quite strict. So if it's a one-off seizure, you can only reapply after 5 years of being seizure-free and not needing any medication. So this one you can be seizure-free and on medications, you can reapply. But this one you have to not need medications and be seizure-free. And then if you have more than one seizure, it's 10 years. It's just unrealistic. I mean, who would report to DVLA if it's like this? But it's for the safety of the public. And that's all for my presentation.